Welcome to hypercoagulable states. In this video, we will be discussing the antiphospholipid antibody syndrome. Over the next few minutes, we will discuss the following take-home points. The expected laboratory findings are antiphospholipid antibodies and/or a lupus anticoagulant. The clinical syndrome includes a history of thrombosis and/or pregnancy morbidity. Due to high thrombosis recurrence rates, patients typically need long-term anticoagulation. You may recall the coagulation cascade in all its complexity. You may remember that, in addition to calcium, an important ingredient for key steps in coagulation is the presence of phospholipids. These phospholipids come from the phospholipid bilayer membrane of the platelet, identified here in purple. For the sake of simplicity, we represent the phospholipids sparingly, but the truth is that the entire platelet membrane is covered in phospholipids. Although we don't fully understand the underlying mechanisms, certain antibodies are produced that bind up the phospholipids, thus reacting with phospholipids, phospholipid protein complexes, and phospholipid binding proteins. This impairs the balance of procoagulants and anticoagulants and leads to increased thrombosis risk. The main known antigenic target of antiphospholipid antibodies is beta-2 glycoprotein 1 and, to a lesser extent, prothrombin. Other antibody targets include thrombin, the endogenous anticoagulants antithrombin and activated protein C, agents of thrombolysis, plasmin and tissue plasminogenic activator, and the annexins 2 and 5. Finally, the phospholipid phosphatidylserine. Let's discuss antiphospholipid antibody syndrome's clinical manifestations. They most commonly include deep vein thrombosis, findings of thrombocytopenia, and skin findings of livedo reticularis. Some patients will present with arterial thrombosis and pulmonary embolism, and a smaller subset will experience pregnancy morbidity. Let's drill down a little on the pregnancy morbidity. In antiphospholipid antibody syndrome, pregnancy morbidity can occur in three categories. The first is one or more explained fetal deaths at or beyond the 10th week of gestation. Secondly, is one or more premature births before the 34th week of gestation due to severe preeclampsia, eclampsia, or placental insufficiency. And thirdly, 3 or more unexplained consecutive spontaneous abortions before the 10th week of gestation. Let's discuss the laboratory findings. These include the presence of anti-beta-2 glycoprotein 1 IgG and/or IgM antibodies, the presence of a lupus anticoagulant, and findings of anticardiolipin IgG and/or IgM antibodies. Other common laboratory findings include thrombocytopenia and a prolonged activated partial thromboplastin time in patients with a positive lupus anticoagulant. Patients with antiphospholipid antibody syndrome have a high thrombosis risk. They also have a high thrombosis recurrence risk. The risk of recurrence is highest with triple positivity. Positivity of all 3 antiphospholipid antibody tests is also associated with the highest risk for thrombosis and pregnancy loss. Next is lupus anticoagulant positivity, which by itself has a stronger recurrence risk factor than the other 2 antibody tests. Let's touch briefly on management. The primary management strategy is therapeutic anticoagulation with a vitamin K antagonist, INR goal of 2 to 3. Unfortunately, therapeutic anticoagulation is unsuccessful in preventing recurrence in 5 to 15% of patients. These rates appear to be higher if a direct oral anticoagulant is used. Therefore, for oral anticoagulation, vitamin K antagonists are recommended. In summary, the main lab findings include the presence of antiphospholipid antibodies and/or a lupus anticoagulant. Over and above lab findings, the clinical syndrome includes thrombosis and/or pregnancy morbidity. Due to high thrombosis rates, patients need long-term anticoagulation, typically with vitamin K antagonists. This ends the video on hypercoagulable states, a focus on the antiphospholipid antibody syndrome.